thank you very much for coming. And first, I start off with a show of appreciation because this room is at the furthest of level 22. And it's not that easy to find. So congratulations. And I thank you for joining us for the last 2 hours of today. And the theme for this session is actually on decolonization of global health, but very specific from the lens of economic distribution and resource allocation. And we will focus quite a bit on the discussion around official development assistance aid funding, the ODA funding. And in my opinion, actually, this session is the most important parallel session of this time slot, because we have other parallel sessions that's happening concurrently. One is going to be on knowledge production, how decolonization is actually affecting knowledge production. Also on the migration of human resource for health, there's one on gender and diversity. All of these topics are important, but I do think why this is important is because we need to really look at how financing is affecting the world order and even how they are shifting their priorities in line with the current trend of decolonization. So to join me today, well, I should start off by introducing myself. My name is actually Y.Y. Teo. I'm the Vice President for Global Health, as well as concurrently the Dean for the Saw Swee Hock School of Public Health at the National University of Singapore. I will be the moderator, but I'm not the important person. The important people are actually the very distinguished and well-informed panelists that will be joining us. So perhaps I could invite on the stage, firstly, Her Excellency, Ines Binawahou, former Minister of Health from Rwanda, and also former Vice Chancellor of University of Global Health Equity in Kigali.
In my country, there is only three excellencies: the President, the head of the Supreme Court, and the head of the another one.
But today you are our Excellency.
The Parliament, yeah, the Supreme Court and the President, so, and none of them.
Actually, the brief that I gave them was we will have fun this session. And I hope all of you will enjoy this particular session this afternoon. And joining Ines is, of course, Professor Calypso Chalkido, the Head of Health Finance at Global Fund. Thank you for joining us, Calypso. And then also following that, it's Dr. Saida Makimoto, the Principal Research Fellow from JICA. And finally, but definitely not the least, it's Professor Kun Tang, who's currently at the Tsinghua Van K School of Public Health and also the co-chair of the WHO Advisory Group for Adolescents Health Metrics. Now, part of the reason why I say this is going to be one of the best parallel sessions is because if you remember what happened during dinner debate last night, we had Ines and Kun on the winning team from the Global South. So you could imagine that today's conversation is going to be just as lively, if not livelier. Now, we started off by talking about what is the objective of today's session, because clearly there are issues around equitable resource distribution. And this theme of decolonization has indeed resulted in many of the international funding agencies to shift their priorities, that it's now much more localized. I think we heard in the plenary earlier on, this localized priority setting, including a shift from funding vertical programs to really looking at much more horizontal health system strengthening elements that is going to be much more sustainable and permanent for the recipient countries. But at the same time, I think we also heard from yesterday's opening session from Professor Mahbubani, where he talks about some of the politics in terms of even aid funding, because the reality is that financing through a neocolonialism approach is a new form of influence in terms of how recipient countries are required to spend some of the aid funding that they receive, or even specific contractors that they are required to bring into their own country that is from the aid-giving countries. So I think this geopolitical aspect of financing is actually a very important element for us to address. And of course, today we have two global funders from Global Fund and from JICA, And also we have 2 country representatives from Rwanda and from China. Now, of course, whenever I say country representatives, I always make a caveat because some of the comments that they speak may not necessarily speak for their own country, but it could be their own opinion. So please do remember that for our panelists.
I told you I'm not the president, I'm not the head of the code. I just myself.
And actually, when Ines got off the stage yesterday, she said, do exactly the opposite of what she said yesterday. So, and I think there is also an increasing role for multilateral development banks in really shaping alternative financing methods, including working with the local governments on mobilizing domestic resources. So the objectives for this afternoon session actually is very straightforward. We only have 2 objectives. The first is to hear from our panelists around how resource allocation and priority setting have changed in light of this decolonization agenda. And of course, I should highlight that this decolonization agenda globally really came about because local priorities have overtaken international funding priorities. That I do not think that it is because of this decolonization agenda that countries at the local level have actually shifted in their posture. I think the countries themselves now have a greater understanding of what is needed, and that is why international funders are now becoming much more connected with the local needs to fund that development. Now, that's the first part, really to understand this shift, this evolution of financing and priority setting strategies. And then the next part, the second aim, is really to discuss some of the challenges and the local opportunities from this global shift. So that's all I would do today, and that's the part that I play, because now the stage turns to our panelists. And with that, perhaps I could invite Calypso first. You could decide whether you'd like to be here or...
Maybe I'll stand.
All right, then. Calypso will share her views from Global Fund. Thank you very much.
Thank you. Thank you. Thanks very much. Okay, so I've made some notes. Since I'm going first, I was going to spend a few minutes sort of rehearsing some of the macroeconomic stats, though I'm sure you're all more or less familiar. So the first message from me is that macroeconomic headwinds are facing the world. We know domestic financing is important. In fact, it cannot be an optional extra when you talk about financing disease responses and health system strengthening. However, we're making this argument, all of us, for governments to invest more locally in their health systems at a time that's very difficult, very tough for economies, especially in the African region, where the Global Fund, and I'll talk a little bit about what we do, invests over 70% of its grants. And traditionally, growth has been the main driver of domestic spending, more so than prioritization by governments. And growth seems to be picking up again, but growth has been and is, at least most recently, very unequal, with about 70% of global growth in 2023 driven by Asia and only 4% by Africa. And to make matters worse, there's also been stagnation in government revenues. So several low-income countries, again, mostly in sub-Saharan Africa, have been consistently collecting less than 10% of revenues as a percentage of their GDP over the past decade or so. And this continues to be a major obstacle to countries being able to finance health, education, and other social causes. And then, of course, we've had the COVID pandemic and the policy response to the pandemic, which have caused scars that haven't healed yet. And then monetary policy choices of developed nations, resulting to some extent in inflation, food, fertilizers, energy, and a growing public debt. And in fact, indebtedness is a main problem when it comes to financing health through domestic funds and potentially increasingly also global funding. 38 countries globally are at high risk already in debt distress. And the median cost of servicing debt is over 10% of government revenue globally. Now, in some countries, this median masks quite significant ranges, and in some countries, debt servicing is over 50% of government revenue. And things will get worse before they get better. So the IMF estimates that interest payments will go above 20% of government revenue on average in Africa by 25, to a large extent because throughout 24, a lot of the Eurobonds that African governments issued, whilst they could borrow money in the markets will hit the wall of maturities this year. So I think things will be getting worse. And on top of that, we've got the ask for climate adaptation costs and to some extent mitigation that could top 50 billion a year by 2050. So these are all large numbers, but are very much felt on the ground in countries when it comes to prioritizing health. So it's a challenging setting to make a strong argument for more spending on health, not just flatline spending or going back to the pre-COVID levels, at least for health systems, but actually spending more. Now, how are we trying to make this argument in the Global Fund? It's a bit of a busy slide, but that's the main one, really. So we've got sort of a multi-pronged approach. I want to talk a little bit about our more money for health approach and a bit about the stuff we're trying to achieve on the efficiency side. But just to say, the Global Fund is the largest health fund. We're bigger than all the climate funds put together. And most recently, we've been spending about $5 billion per year. We make grants in over 100 countries around the world. And our focus is TB, HIV, malaria, and health systems. And we very much believe that all of these are interrelated. Now, when we talk about more money for health specifically, and our chair mentioned the importance of multilateral development banks, and very much have scaled up our engagement with MDBs and had the opportunity to talk to leaders from the World Bank, like Feng, who I see here, and we're very grateful for their support in this effort. And this is a complement to our traditional grants, and we would like to scale it up. With the majority of the world's poor now, once again, living in the world's poorest countries, the ability to target aid and also concessional financing, concessional lending to the poorest countries is really important. IDA is an important tool, but we're also working in IBRD countries with the bank and other MDBs to increase the concessionality of lending and entice countries, if you like, to borrow for health where this is possible, with all the caveats on indebtedness. We work with a number of national governments and the likes of the World Bank to drive resources towards health systems and TB, HIV, and malaria. This is an important sustainability strategy as well, I think, as the blending of grants and loan money is really helpful towards less aid dependence. Another thing we're trying to do more of is debt to health swaps. We've traditionally worked on sovereign debt. So wealthier countries sort of forgiving, writing off, if you like, part of the debt the country, recipient country owes them. And this part of this translates into buying health outcomes. But increasingly, we're considering working also on Eurobonds. We haven't done anything in this space yet, but we're certainly exploring it. That's quite important because the composition of debt recently, especially in low and middle income countries, has changed significantly over the past couple of decades. Another element is value for money, and that's again quite important for us. I mean, we do know that 30 to 40%, perhaps more, of above international reference pricing for pharmaceuticals is paid for by many countries in the so-called developing world. We also know, again, with regard to procurement, that about 50 of the poorest low and middle income countries could achieve recurrent annual savings of up to $26 billion per year. About 40% of the $63 billion that countries spend on drugs, on health products, by efficiencies, by meeting international reference prices, for instance, or improving the way they negotiate with pharmaceutical manufacturers. And this is a big number. It could cover 300 to 400 million people with a basic universal healthcare coverage package. So we do think that the Global Fund is an opportunity to support procurement, whether it's pooled procurement, but also priority setting, and that's a space where I would like us to work more on. I've had the honor to work with the Thai HITAP for years. They've been doing fantastic work, and with colleagues around the world, and I think the ability to prioritize the things that countries spend their domestic money on is quite precious, quite important. So this sort of explicit priority setting matters. And increasingly, now I've joined the Global Fund, it's been 3 years now, looking at benefits packages, it's really shocking to see how few of these have been updated and how few of these, especially in low and middle income countries, actually include any of the so-called verticals. So TB, HIV, malaria interventions are rarely included. And in fact, increasingly those budding health insurance schemes explicitly exclude populations who are affected by TB, HIV, malaria. Now, of course, that's perhaps a rational choice to the extent the likes of the Global Fund are there, but we have to work, and we do work increasingly with governments and health insurance funds to integrate and make sure that populations are not excluded, and we can increasingly channel our own funds through those mechanisms. Now, I'm wrapping up just to say that ultimately spending on health is a political decision. We work closely with the AU and networks across the African region to make the case for domestic spend. The Thai UHC scheme reform shows that it is truly a political decision. And I think I was reading this statistic the other day that six of the most indebted, if we just look at the debt servicing over government revenues, 6 of the most indebted sub-Saharan African nations have consistently over the past 15 years or so been spending twice as much as a fraction of their GDP on education as they have been on health. So again, you might want to talk about fungibility and crowding out, but ultimately it is a political choice. So that's summing things up. So we're focusing, the department I work in, I run the Global Fund with our partners inside and outside the fund on co-financing, working alongside national budget holders and aligning with national budgets, strengthening public financial management systems. We know a lot of the money ministries of health get stays unspent for different reasons on the harmonization agenda, etc. We can talk about this in the discussion. So I just wanted to, since we had the water feature also, the opening, I thought this was relevant. And I think it is about working together, and certainly PMAC brings people together towards a common cause. So I'm quite heartened, and thanks very much for the opportunity.
Thank you very much, Calypso. Thanks for your opening remarks. So I promise you that you would have quite a lot of time to engage with the panel. So please do think about your question as you hear the presentation, because we have each of them provide about 5 to 7 minutes of brief comments. Next, could I invite Saida from JICA to provide your brief comments of JICA's funding strategy and how it has changed.
Okay, thank you very much, YY, to invite me to this important session. I'm Saida Makimoto from JICA, Japan International Cooperation Agency. As many people know, that JICA is a bilateral ODA implementing agency, which is in charge of the implementing grant technical cooperation, and ODA loan, yen loan, and grant aid in integrated manner. And Japan has a different approach of ODA, the multilateral cooperation, but it's not handled by JICA. And it's done by Ministry of Finance or others. And in my talk, I'd like to explain about JICA's corporations, how we are, how we are setting the financing or funding strategies or cooperation strategies, and how we are going to change in the midst of this political crisis or the difficult situations. The first, how we are providing bilateral aid of technical cooperation, loan, and grant aid. Basically, we are a bilateral cooperation agency, so our cooperation is guided by the Japanese government policy. And it is, of course, to contribute to global peace and stability and prosperity, but also it includes the bilateral relationship between Japan and the target countries. And it includes the social relationship and economic relationship both. And JICA has our sectoral plan, and as well as country plan to have a cooperation. And I'm in the health sector, so our department has cooperation, that strategy of health sector, as well as subsectoral strategy like maternal child health and so on. And we are trying to meet the countries' mortality or evidences in the world and so on. And then, but there is a different scenario of Japanese government based on the country's relationship or our experience in working experience in the country and so on. So that we have to mix, we have to integrate the idea or plan. We have to integrate the strategy to make the plan for each country. And then we make the project list in the rolling plan of 5 years. And then we implement, we share, we develop this, that document in collaboration with partner countries. Then we have a regular dialogue with the partner countries and develop together. And based on that, we make it our, we make our cooperation as transparent as much as possible and to make it, yes, and so on. And then regarding health cooperation, in the past, we have been mainly utilizing technical cooperation and grant aid. But from mid of 2010, around from 2015 or so, now we utilizing development policy loan that is general support to the country, and we utilize that scheme to strengthen the country's financing mechanism and the policy to promote the policy actions by the country in collaboration between the Ministry of Health and the Ministry of Finance together. And that is very important to have sustainable health financing mechanism. And we implement that kind of system in Kenya, Senegal, Egypt, Cote d'Ivoire, and we are trying to expand that scheme. And usually we try to work together with World Bank or other development bank. It's not very strict co-financing, but we share the vision or framework and try to harmonize our system as much as possible. And it makes more easier for the country to manage the system. And currently, we are working on the new innovative system of private sector, private financing. In G7 summit, Hiroshima last year, they agreed to establish the new initiative of triple I, so-called. It is impact, sorry, I have to check the official name. Yeah. It is Impact Investment Initiative for Global Health. It is to promote the mobilization of finance from private sector to global health, as well as to monitor together how the private financing is going to be invested in which area. And then we understand the private sector have to earn money, and it is not sometimes easy to share the goal. But to have such a monitoring framework together and share the common goal, we can have a similar direction to contribute to global health, and that would help the shortfall of the global health financing, I think. That is my
Thank you very much, Saida. So I think what we've heard so far from both JICA and from Global Fund have very clear similarities. And I will try, if I can, if my notes are accurate, I'll try to summarize some of the similarities, because Global Fund actually work with the MDBs to leverage additional funding to support the work. And actually, Saida also talked about the Impact Investment Initiative, where JICA now is working with private financing, really to try and see how to bring all these alternative forms of financing together to fund global health initiatives. That's one similarity. There's also another similarity that both Calypso and Saida talk about, which is the shift towards really identifying what are the country level's needs. And I think there's this shift of the power balance to really localize aid that is necessary. And that was exactly what I think Saida mentioned as well, that there is a joint development with the partner country to really identify how the funding resources will support. And I think one aspect of JICA that we always have seen, but it was never very well articulated, is that JICA actually goes beyond just financing for health development, but JICA funds a lot of national developments looking at social infrastructure as well as education as well. And I think that highlights the very Japanese approach towards approaching health, that it is not necessarily just investment in health, but rather a lot of the upstream investment in national development, in human capital development, fundamentally will have its payoff in dividends in health. And I think those are some of the very key important elements. And I think one last aspect that Saida talked about is that long-term engagement that JICA typically has with partner countries. So those are some of the very important insights that we have heard so far in terms of the shift. And it's not always just so positive, because I think what we've done here is to paint the picture in a very positive manner. And the question is, are there some of the challenges faced by local countries? And this is where we have Kun as well as Anes that will guide us through some of the developments in China and in Rwanda. And I think, Kun, you have one of the hardest tasks today, because clearly you're on the stage, and I have been saying that you will be speaking about China's evolution in this space, because clearly China has moved from a recipient of international aid funding now to one of the largest funding and aid provider. And I think you would correct me on that statement in a bit, so I stand corrected. And then also because we've all seen that the China's Belt and Road Initiative have influenced the world, many parts of the world, in terms of their national development, that has an impact on health outcomes. And right now, I think this is a year for China-Africa cooperation, and I think that's something you will talk about. So there is one question that I hope you will guide us on, and is this a sign that China is a new colonizer? And I allow you to actually correct me, because I think we discussed this in the preparation for this session, and it's a question that is on the top of many people's mind. And I feel that this conference is exactly the platform that we try and answer some of this. So that's why I mentioned, I preface Kun's difficulty in trying to share some of this, his insights and his perspective on these important issues. Kun, over to you, please.
Thank you. I'm going to stand on stage. Well, thank you, Professor Teo, and also the organizer of this meeting for inviting me to talk from the perspective of China. And I realize that I've always been put into a hard position of difficult tasks during this conference. So, so I hope I can get this done. This is my last task for today, for this conference. So I'm going to talk about the decolonization of global health from the experience of China, and trying to answer, of course, in the meantime, some of the questions raised by YY and perhaps a lot of the audience here today in this session. As YY said, China has already transitioned from a ODA recipient for from development agencies, development partners, to an emerging donor, as you can see in this figure. So by the year 2008, we already received less funding from overseas development aid than we disperse to other parts of the world. So that is a milestone for China as it turns into an emerging donor. So it's almost 10 years ago, right? It's more than 10 years ago, actually. So how does China work as an emerging donor? As we can see, there has been several flagship programs that China has been very proud of. One of them is the China-aided African CDC headquarter project, where China helped the African Union to build its first CDC, and also trying to leverage our technical experts to work with the African people, African professionals, to tackle on their health issues, especially with regard to the emerging pandemics in Africa. And as a traditional scheme, China is very good at sending our medical teams overseas, and that contributes to global health. Especially during the COVID pandemic, China dispatched 37 anti-epidemic teams to 34 countries to help them to take necessary measures to fight against the pandemic. So there are several things that has been going on, but I need to first put China in the global health financing, placing China in the global health financing where we are at. So if you look at the table on your right-hand side, China is actually not doing bad. We rank number 10 of global health, development aid for health globally. And that is just after Sweden and slightly before Austria. But if you look at the areas where China dispatch is ODAs, especially development aid for health, a majority goes to the health system strengthening. As you can see, the proportion of DAH flow to health system strengthening counts about 92%. If you compare that with other countries, other donor countries, this is quite unique. And another figure that I showed on the screen is when you plot the gross domestic product per person versus the development assistance for health per gross domestic product, you can see China is actually above the line, above the average. So China is actually doing well. That means at the given level of GDP, we spend a better share of our GDP to help contribute to global health. And as I said, the aid behavior is quite unique or even strange sometimes if you look at it. Majority of the Chinese funding go through the China Ministry of Commerce. As you can see, a largest chunk, more than 50%. And some go through the National Health Commission, and some go through the the Ministry of Education, other ministries. So those are mostly bilateral channels. As you can see, only a very small layer of Chinese funding go through multiple agencies, like multi-country agencies, as you can see at the very bottom. And if you look at the health focus area, China is still quite unique, if you put it that way. We seldom put our funding through specific health areas, as you can see on the top, but rather a majority of the funding goes to the health system strengthening and goes to the provision of supplies and human resource training. So that is quite different from other countries too. But China does represent a huge chunk of global financing if you compare China's development financing versus the World Bank. As you can see, by the year 2015, the World Bank has a total endowment of $253 billion. And if you put China's development financing, that includes China's South-South Cooperation Fund, China-Africa Development Fund, Silk Road Fund, the BRICS Development Fund, and also the Asian Infrastructure Investment Bank, if you put everything together, the total endowment provided or committed by the Chinese government is actually larger than that of the World Bank. So you can see it's a huge amount of money that we're contributing. So what are the interest areas of China? So we can see that from one of the Belt and Road high-level meetings, which was held in 2017. As you can see, those are the areas, namely health security, maternal and child health, health policy, hospital management, human resource, traditional medicine, health system, and health industry. Those are the areas where the Chinese government is aiming to invest along the road, Belt and Road, about the Silk Road Initiative. But what are the basic principles of China's foreign aid policy? I mean, we always put that in our paper, in our policy paper, and which was put nicely by saying that we respect independence, there's no strings attached, we we advocate for equity and co-development. The project must be reality-oriented, and there have to be adapted locally with innovation. So those are the 5 basic principles of China's foreign aid. But as YY have rightly mentioned, there has always been criticisms about China's foreign aid. As you can see, a lot of journals, a lot of media have covered Chinese aid always by saying that Chinese aid in Africa are debt trapping. I mean, it's economic dependence, and also it serves the prioritization of Chinese interests rather than the local needs. So this has always been the criticism of Chinese aid. So why would I give me this task of answering whether China is a neo-colonist or not? I can't. I can show you the result of several research papers, how they concluded. So you can see there are basically 4 studies about China's development aid for health. To answer just one question, is China's development aid for health allocation for need, for merit, or for self-interest? As you can see, those are published on major global health journals, and findings are quite mixed, I have to say. In one of the papers that we have published, I published personally, we found that the most significant factors influencing China's allocation for DAH were the recipient country's GDP. So the poorer the country is, the more likely the country will receive Chinese aid, and also the human rights conditions. And donor interests such as trade and natural resources only slightly influence the allocation of China's DAH. And there are also other academics who found that national capital cities were slightly associated with allocation of funds, which means China is likely to pour our money to the capital, where the resources are less needed, actually. And no health-related indicators were identified to affect the project allocation, except for the facility delivery rate and under-5 mortality rate. So this is a paper also published by, I think, a group of Chinese researchers. And overseas researchers found, for example, there is statistically significant relationship between aid to China and Chinese export to Africa. So that is to say, our aid is related to our trade with Africa. But last but not least, Professor Griffin, who was also part of the panel yesterday, she found little evidence that China target health aid preferentially to natural resources-rich countries. So these are the findings from the academia. So I'm sure you may have your own judgment or your own taking of the finding, but so this is to answer it from the academic perspective. And last but not least, let's talk about the opportunities and challenges. A lot of you have heard of this Belt and Road Initiative. There are, of course, a lot of criticisms, but also a lot of compliment about this Belt and Road Initiative, because it really covers China with Asia, Central Asia, all the way to East Europe, and also Africa and Southeast Asia. And primarily, it's not an aid plan, as many of you would have thought. It's essentially a development plan which promotes the trade economic exchange between China and the rest of the world. But along this Belt and Road Initiative, there are also health elements which China is trying to promote, both for profit and non-profit, I have to say. And this year, as well I mentioned, this is another big year. Last year was the anniversary, I think 10th or 15th anniversary of the Belt and Road Initiative. So there was a big event happening in Beijing, which the Chinese government has announced $100 billion new investment to the Belt and Road Initiative. And this year is a China-African Forum on cooperation. So Chinese government again is going to announce major investment with Africa. So we are looking forward to that development too. So to sum up, we do believe that China has proved that developing countries are capable of solving their own health problems like China. So we used to be very poor, but we do with multilateral agencies, we work with international partners to strengthen our own health system. So we do believe China emerging as a new donor, but previously as a recipient country. From our experience, we really would like to push for a paradigm shift to believe that through continuous economic and social development, and developing countries can solve their own health problems. So let me pause here, and I'm happy to answer questions. Thank you.
Thank you very much, Kun. Thank you. So you could see that it's not an easy task that Kun has signed up for. But there are a few points that I thought it's very worth emphasizing, because the first point that I took was that there are academics in China that are looking very transparently and very frankly at China's positioning and the development aid for health from a geopolitical lens. To what extent it is for need to address the needs of local governments, merit, or for self-interest. And I think that it's something that perhaps we didn't realize, that that's a group, I'm not sure whether it's a large group or a small group in China, of introspection that's happening. The second point that I took from what Kun, you have mentioned, is that actually a vast majority, 94% of the funding actually is dedicated to health system strengthening, human resource training, and technology transfer. And I think that is something that we should remember, because we'll come back to that. This is a very important point when we start to think about foreign aid. And then the next was the bit about context specificity, because you showed 5 points. And one of the points was actually working with local governments to tailor what the adaptation and the contextual specificity that is needed for some of the aid developments. And I think that it's an important point for us to remember as well as we come to the discussion later on. And Kun, you have painted a very clear picture about how China has seen and learned from the world, and as a developing country is emerging as one of a very developed nation on its own right. And actually, it's not just China that I will talk about, because Rwanda is also one of the countries that have developed tremendously well, particularly from a health perspective. And Ines actually taught me yesterday, gave me a very good lesson in the development of Rwanda, that is one of the least corrupted country in Africa. It has very...
In the world.
Rwanda also has the ambition to develop its universities to be one of the world's most renowned institutions.
Certainly in global health, and we are already there.
And then there are an emerging academic excellent vision, as well as a vision of its own people to have that sense of social responsibility within the country. So Ines, guide us. How did this transition happen, and particularly what was the relationship between Rwanda and the international funders to lead the development? So your inputs, please.
Thank you for giving me the floor. Good evening. Oh, yes. Good evening, everybody. So this is a very interesting topic because it is a two-way responsibility. The responsibility of the country that come, I don't like donors, you know, but come to help you in your development, and you that manage your own development. And it has to start by you. You doesn't have to wait to have an opportunity to know what you will do if you get money. Because the development partner will not let you the time to start thinking when he's there ready to help you. Because the development partner have to spend the money within a year according his own parliament, Congress, and accountability to his own country and people. So you need to be ready. And it is this story of the guy who say, me, I never travel. And at a certain point, friends say, okay, we have collect money, you can go and travel. Yes, but I don't have a passport, you know? So that means don't complain, be ready. I always think also that nobody loves more the Rwandan than Rwandans. Nobody loves more China than the Chinese. And if you have a good plan and you are ready, when people come from outside and decided to help you, you just put your plan there and say, what portion of the cake you take? But take nothing out of my cake. And then the dialogue starts. I have to say that many countries that are among the development partners are not really there to develop you. They are there to buy your vote to the UN, a portion of your land to put the military, or something else. So it's not genuine. But it's not because it's not genuine that you cannot use it as you need and as you want, because a country is like a kitchen. Nobody tell me how I have to cook my pizza. I cook it as I like. So you are ready, and when you have the opportunity, you just ask the people to deal with what you have. And everything starts there. When I started by running the National AIDS Control Commission, and I remember that time, early 2000, the only money, the big money in the health sector was for HIV, for one disease. Why? Just because very powerful team of men in America have managed to move the world. Young white men have moved the world, and that's good, I'm not against. And so, money flow in HIV. It's an opportunity. Me, I tell you, if there is a global fund for grandma, I will take the money and save newborn. It's just to put them in the same hospital and make it a good hospital. You know, you can do what you want. It's not because the rules are there, you have to use your imagination and the laws to force the partner who want to help you like you need. But for this, there is a rule. Having zero tolerance for corruption. Because then you can stand strong. And also have your plan. I had many colleagues who make the deal, but at the time to say where to put the money, the plan was not well done. So they didn't get good results. So this is, have your plan, have strong national regulation and fight corruption. And corruption is two ways. I don't believe that corruption is more in the developing world. No. And also, some development partners push you to be corrupt. Come, we'll pay you some holidays in that place, and but you will be kind with us, and you will, etc. So that means it's really a multifaceted situation to deal with the money that Congress or Parliament in the Western world vote to help countries in their own development. Now, when you have a plan for the health sector, because we talk about the health sector, the plan you have in the health sector has to really match the national development plan. So, first of all, you have a national development plan for all sectors. And you extract yours and you make it in detail. That means when I plan to have a hospital in the far north, I need the Minister of Infrastructure to plan a road to go there. I cannot do things as a standalone. He cannot do a road where nobody will go. So that means government has to govern as one. This also helps the minister, because, you know, in many countries, many people say, oh, the Minister of Health is like the Minister of Social Affairs. They have no power in the government. No, that's not true. You have a strong power because, but you need to have your plan with key performance indicators and agree with all your partners that, your partners in government that that's what you work for. So, integration of the development of the health sector in the national development plan. Know the national plan. That means I have to know what other sectors are doing to really work in synergy. And second, coordinate your partners. And that's true that partners are coming with, me, I'm doing this in neonatology. Okay, you do that in neonatology, but you'll help develop that hospital, that aisle. It's not only neonatology. You contribute to the development of a hospital and access to care for a population. So integration, holistic approach, and really put all the donors in the same table when you discuss your plan, but be on the drive seat. You are the boss. And you explain them where the money will go. And you fight corruption. They all love that. You know why? Because if you work well and you have good results, those development partners have good faith in their own Congress and Parliament. So they want to dictate you, make sure you put law, you know, sometimes we have passed law overnight because some development partners want us to buy drugs that were branded, and we say, no, we want generic because we can treat more Rwandans. So we pass a law rapidly that you are not allowed to buy something of quality that is more expensive than something else of the same quality. So I say, it's not me. It's the law. You don't want to be illegal. I can because I'll go to jail. So good coordination, good collaboration. A minister of health is nothing in a government if he's not working with the others. The minister of local government for the infrastructure, the minister of finance for fighting for the same money. You have the same language when you go and visit those countries. And also a coordinated way to manage the country. I think I will let that there. So when you do that, no need to decolonize it.
Thank you. Thank you, Ines. Can we give a round of applause for Ines, please? I'm not sure whether you were taking notes, but I was, and it sounded almost like a recipe for developing a country, and not just a recipe for making pizzas. But I'll just quickly highlight some of the points that Ines taught us, because in my introductory comment, and it's the same as what Calypso and Saidia talk about, there is this joint priority setting between now 8 agencies, development partners, with the recipient countries. But the question that I think Ines asked is whether local governments are ready to engage these development partners. Do they even know of what their local priorities are? Because how would you otherwise engage? And in deciding what are your local priorities, it comes to the second lesson that I learned. It's around that the health sector development plan cannot be separate from a national development plan. It has to be integrated. And that phrase that I hope the rapporteurs will take note, government has to govern as one. Please make that note, okay? Because I think that's where the health sector leaders, perhaps Ines yourself as the former health minister, have to reach out to the other ministerial portfolios to really discuss how would your development plan affect my development plan for health or in health. And I think that is a second important lesson. And the third is that once you have your local priorities, that's where you tell the development partners and the funding agencies very clearly, these are my priorities. Are you going to work with me? If not, go away. I will find someone else that will. I think...
Absolutely. Because after that, they go to the Minister of Finance and try to sack you. And I remember somebody asking my president, we had a very kind Minister of Communication who just gave a talk one day to the youth and said that you need to be very polite, very kind, etc. And after that meeting, we were all taking a drink, and somebody asked the president, but you you agree that we need to be polite and kindness. So why do you tolerate Binagwaho to behave like she behaved? And he said, I need people who can say what I'm not always allowed to say. So, and in an international organization, when we had meeting at the World Bank, it was the same. So I didn't did something extraordinary because I was well supported. But I just want to say that if you are a Minister of Health and you don't have working in this philosophy, first create the philosophy. First educate your colleagues so they became your partners.
Thank you, Ines. And I would like to invite Calypso and Saida to actually respond to both the inputs that you have heard from countries like China and Rwanda. Any reflections based on what they have said? And while we are hearing from Calypso and Saida, if there are any people who have questions, can I invite you to approach the mic and then two things: let us know who you are, where you're from, and then state your interventions or the questions that you have. And if you have a question specific to someone, please also let me know who that question would be directed at. So please help yourself to approach the mic. But first, perhaps Calypso, immediate response to what you have heard from Ines and Kun.
Well, I think it is a good recipe, and we're working very well in Rwanda. It is a special situation because of all the ingredients that you've set out. So be prepared, know what you want, zero tolerance for corruption. There is the tension we've discussed about between localization and fiduciary controls and checks, because our bosses want, as you said, to make sure the money goes where it's supposed to go. So if the trust is built and they have trust in the recipient government, then you can be very innovative and very flexible and imaginative. When that trust is broken, it takes many years to rebuild. So preparation, connection, these plans, and we are guilty, the Global Fund and other donor institutions, of driving sectoral or even intervention-specific or disease-specific plans. And this is a contradiction in terms. I mean, you cannot plan for a vaccine or plan for a disease. You have to plan across government, as Agnès said. And we need good governments that push us in that direction and tell us, no, you cannot plan like that. And increasingly, we'll have to think this way if we're going to talk about sustainability and aid independence. And we have to. PEPFAR is telling us, for instance, that gradually things will move on. So we're working with them and governments on this. And again, you need a plan, and you need cross-sectoral cooperation, and the plans need to be prioritized, costed, and budgeted for. A plan that's a wish list, that's aspirational, has no connection to budgets, is a problem. Perhaps not now, the money is plenty, but soon it will be a very big problem. It creates liabilities on government. So, yeah, I agree.
Yeah. Because, in fact, for the aid, we have only three approaches. You have an approach as projects, you have an approach as program, or you have an approach by budget support. The best for me is the budget support, because I can increase health uptake by creating a road, so it's not in the health sector. However, better to create another hospital here, create a good road so the people, and have 2-3 ambulances is more efficient. So those are very important points, and people go home, look at your plan. Is it integrated? Is it holistic? Did you put all the players? Because if you take also the social determinant of health, this came after, because it came when Paul Farmer and Jim Kim did this wheel with the social determinant of health. And we understand that it's really important. You have really to work on all the social determinant of health for the sustainability and for also community ownership.
Thank you. Saida, any additional points to add to that?
Thank you very much. Yes, the Japan's DAH is about 11% right now of our corporation. And it was before 5%, but it increased to 11%. It is maybe because of the budget support. But the budget support is one of the good approach, as Agnes mentioned, but we best. Yeah, but we understand, in addition to that, the capacity building is very important. The JICA is having technical cooperation in line with budget support and to strengthen the human resource and the mechanism and good supervision monitoring system to make the system work better. And so Kun mentioned that in your health system, strengthening human resource development was one of the key issues. The JICA also understand that health system strengthening and human resource development is very, very important to manage your country's development plan as a whole, I think. And in addition to that, the social determinants of health, yes, the not direct input in the health sector, but also the infrastructure, road construction, and energy, sustainable energy, or good the wash support is quite important. And now JICA is trying to have a collective impact, at least within JICA's cooperation. But it is challenging because their goal is very different by sector. But we are trying to our best to have one national development goal to achieve.
Thank you very much, Saida. And I think that this point on human resource for health development is something that I will come back to because it's a very important point. And I know that there is a parallel session that's discussing HRH migration as well. And I actually would like to bring that into this panel as well. But before that, I think we have 3 questions waiting, or 3 comments. Perhaps I could invite the gentleman, followed by the lady, and then the gentleman at the back. We'll take all 3 at the same time.
Thank you. So my question, Sani from Myanmar, my question is to the former health minister of Rwanda. When someone become a minister, their designation change, like His Excellency or Her Excellency. So in Myanmar, like His Excellency, Professor, Doctor, something. With that change, it comes with an ego boost as well. No, I'm not. I'm really not saying that every minister is egotistical. I'm just saying, I just want to learn from your experience. And as someone who work on health, national health plan development, one of our challenge is that putting the Minister of Planning and Finance and Minister of Health in the same room. There are a lot of politics that we have to navigate. So I just would like to learn from you that can you give me a crash course on how do you navigate those challenges and how do you overcome those political obstacles? Thank you.
Okay.
Thank you very much, Sunny. We will take the questions. We'll take the other 2, so you at least have some time to think about your response.
Yeah, you heard them because I love that.
I will take note of the questions, particularly on the ego boost and also that difficulty in managing portfolio, because I think in most countries, the Minister of Finance actually is seen as an outranking minister. It outranks the Minister of Health in most countries, including in mine. Ministers of Finance is more powerful than health, but we'll come to that. So that was a question from Sunny from Myanmar, and then maybe this lady here.
Yeah. Okay, thank you. I'm Xiaopeng Qi from Center for Global Public Health of China, CDC. And thank you for sharing all of these findings and experiences, especially not from donor and also from recipient. So from my understanding, the way to get the universal health coverage, this is from several steps. The first is maybe the reality is the different countries have different resources, and then the more richer they have more resources and more capacity, and also have a very good health outcomes. So that is why we need to do the health aid. And then the second step is we try to get to the equality, that is give them the same resources, but it doesn't work. So we move to the next step, it is the equity. So most of us are talking about the equity. That means you need much and we give you much. It is different resources for different countries. So I think that is not the end point. The ending point should be the justice. The justice means you didn't need any support or help from others. You can do it by yourself. So that is the justice, I think it's the ending point when we do the health aid. So my question is, how could we move from the equity to the justice? I mean, just like Dr. Tang mentioned that China has already graduated from health aid. I'm wondering how could the other developing countries graduate from it? What is the way and then the methodology we should adopt it? Thank you.
Wow, this is a very, very difficult question. So effectively from Xiaopeng T, the lens of how do we move aid from a lens of equity to a lens of justice. And I think this must be a question that I would direct to our funders. Perhaps Calypso, I could prepare you in advance to think about this question. How do we move that lens? Because a lot of this might actually have to be directed by the funders as well. And then the third question that we'll take, gentleman over here.
Hi, thanks very much for sharing your insights. My name's Sam. I'm a public health advisor for the UK government. My question, I think one of the key transformations in the last decade, and especially in the last 5 to 6 years really, has been the emergence of a really strong regional architecture for public health. So I'm thinking in the African context about the Africa Centers for Disease Control, the amazing job that they did during the pandemic, and also in this region, ASEAN and ASEAN's public health institutions. So these are organizations that have the technical expertise, the political mandate, and increasingly the funds to support their constituent member states on public health. And they're kind of providing a much stronger articulation of regional policy priorities, of gaps and needs. And they're also providing new channels for kind of development assistance to their member states. So I'd be interested in the reflections from the panel on what does the rise, of this much stronger regional architecture mean for resource allocation decisions, for traditional multilateral actors, including the GHIs, and bilateral development partners. Thanks.
Thank you very much, Sam. To this question, perhaps I could invite Saida and Kun to think about this in terms of there's a rise in regional blocks, essentially, in the governance of global public health, and whether this is going to be beneficial, if I paraphrase it correctly. And we have seen very clearly the Africa CDC and Africa Union being one of the shining example of what can be done very well, very right, if the region actually come together with financing, with policy, with regulations. And the question is, can ASEAN follow, given that ASEAN has about just half the population of Africa, but it's a sizable group? Equally, are there other blocks that can emerge? And that is actually something we could discuss. But first, the question from Sunny to Anes. This bit about the ego boost as a person progressed from a professor to become a minister, Her Excellency. And I think there's this discussion about national health development plans, but what are the politics when a health minister speaks to a finance minister? Are there problems that the finance minister would say that actually we want to prioritize this development and then health would just have to wait? What are some of the problems?
It's just in your head, guy. A minister is a minister. First of all, we have the same salary. If he or her had more than me, I can say, okay, we are not on the same stage. We have the same salary, we have the same boss. So it's better to consider a government like a football team. I know nothing in football, and I'm worried. But they are a team. They work together. If the Minister of Health doesn't manage well or doesn't plan well, doesn't develop the sector, the Minister of Finance may have the money to give. Is just your banker. Is your banker your boss, or you are the boss of your bank account? That's it. We have different roles in the same team.
I shall remember that lesson and let my health minister know that the finance minister is just a banker.
That's true, by the way.
Let's try that. Thank you, Ernest. So then what, Calypso? This question from Xiaopeng from China, that often there's this lens that we've now shifted from UHC, equality, equity, now we're at equity, but she proposed that justice should be the final end goal. But how do we even move from the lens of equity to a lens of justice? From a funder's perspective, and then, of course, from country's perspective, we could add on as well. So, but Calypso, please.
I'm not sure we are at equity. I guess, I don't know how you reached the conclusion that we've reached equity, and then how, I don't quite understand the stages, but I think economic growth, I mean, in the case of China, for instance, China grew itself out of poverty and out of disease to some extent. So there's a very clear correlation between economic growth. In South Asia and Africa, we're spending roughly the same per capita on health at the beginning of 2000. South Asia consistently prioritized spending through, because it grew faster. It grew twice as fast, ended up spending twice as much. Of course, population growth is also a factor, but if we try and normalize the major factor that drove spending on health, and to the extent that spending on health translates into better outcomes, which it does up to a point, that growth in spending on health was driven by economic growth. And of course, distribution policies, and but nevertheless, China in the 80s, 90s prioritized growth over, say, universal healthcare coverage. This came later, right? So I'm not saying China is the model, but I think that's one explanation. Certainly in Africa also, countries that grow faster seem to be able to spend more, or automatically almost spend more on health as compared to prioritizing. Well, Cara is here and she's done fantastic work on this, the empirical evidence. So I think you can answer this question better than me. But if I may just address the point the colleague made about regional, I think that's a really valid point. And we're certainly working very closely with the AU, and His Excellency President Kagame is a convener and a lead on domestic resource mobilization, and the ALM initiative, the Africa Leadership Meeting, it's been going on for a while now, through having a scorecard, looking at what countries spend, peer pressure, convening heads of state, and continuing to push for more spending on health is quite important. So we've partnered with the AU, have been partners for many years, and we want to do more together. Partnering with Africa CDC a lot, doing some work with them, for instance, looking at alternative sequencing of alternative interventions to tackle malaria, which is a big issue now with the vaccine also out. So many interventions, some quite costly. So what's the best way? Working with supreme audit institutions. We have a conditionality policy at the Global Fund looking at how much countries spend domestically as a means of getting the full grant. And I think we shouldn't be the police in Geneva. We should be using supreme audit institutions who know the country's accounts and have access to them, and they should be doing the policing. I think we need to move away from this mentality of monitoring out of Geneva or Seattle or wherever it is we're based. And to do that, we need to change our processes. And the donors who sit on our boards need to support this shift for it to happen, in Britain included.
Thank you, Calypso. And actually, I was just looking around the room, and I do know that we have 2 additional questions, but I would also like to mention that we have quite a number of donors in a room as well, and also funding agencies, people, whether it's from the World Bank, from the Bill and Melinda Gates Foundation, from the Wellcome Trust. So if at any point in time you would like to make an intervention, please, we welcome you to approach the mic as well. Your input is just as valuable as any of the panelists here, because it is an open forum, and that's the interaction and also the interventions that you provide would be valuable. So before we take the 2 questions, I think we have one on the regional architecture, and Calypso has already touched on some of it. I'm not sure whether, Saida, you have any comments on how do we encourage or even strengthen this bit about the regional architecture for global public health?
Thank you. Yeah, we are a bilateral cooperation agency, but we recognize that regional mechanism, including Africa CDC or an ASEAN mechanism, or vaccine manufacturing network or procurement, regional procurement mechanism was very important during COVID-19 pandemic to have resilient society. And we are having a we have a cooperation to African CDC and we are planning to have a cooperation to ASEAN CDC, especially in the human resource development. For example, in Africa CDC, the JICA extend the cooperation that we have been working in Ghana, Kenya, Zambia on research institute on infectious disease control, and they could serve as a sub-regional center, some kind of CDC, and work with Africa CDC to have function of human resource development and research and surveillance function. So our bilateral cooperation and direct cooperation to African CDC is, let's see, making synergy there.
Thank you, Saida. And actually, I just want to highlight one of the points that you mentioned around collective procurement. And the question has always been that can funding agencies or even countries come together to start thinking about the power of collective procurement or collective purchasing of some of the key pharmaceuticals, including vaccines. And I will just name two regional blocks. One could be in South Asia, between Nepal, Pakistan, Sri Lanka, and Bangladesh, coming together to jointly negotiate with the pharmaceutical companies. Another block could be Laos, Cambodia, Myanmar, Thailand, Brunei. Fairly small countries, but equally with the right health needs. And then whether it is the governments themselves that need to discuss this collective purchasing agreement before they approach the funders, or the funders actually initiate such a discussion. So just something that I wanted to touch on, because Saida, you mentioned collective procurement. Kun, final comment from you before we have 3 questions.
Right, well, thank you. I'm by no means an expert in regional mechanisms, but I just offer my observations. First of all, I think the regional institutes in public health, they are obviously at the advantage of getting closer to the countries they serve. So they know the situation, they are from the countries. So from the point of view of decolonization and from the point of view of decentralization, I think they are important aspect or important part of the global health architecture. But from the institute that we work with, we definitely observe a strong need for financial support, as there's still very much work in progress, taking into, for example, the African CDC. And also we observe a lot of capacity building needs, providing trainings to their human resources and technical support. So I think there are still a lot of things that we need to do to really enrich the capacity or enable the regional mechanisms to work. And I think another major controversy, not really controversy, but another major concern is the legal status of these regional mechanisms as versus to the WHO. Like what the role of these regional entities and what are the decision-making roles in particular when it comes to the global health issues. So I think this is something that the global health community need to solve. Right.
Thank you very much, Gun. So we'll now take 3 questions, perhaps starting from you.
Can I say it's not the global health community who have to solve that? It's the African Union for Africa. It's the PAHO for Latin America.
So it's the countries, the bloc.
Yes, the Council of Health Ministers.
Correct. So, that's where in Africa context, it will be the African Union.
Yeah.
In ASEAN, it will be the ASEAN health ministers.
Yes, and in Latin America, it will be PAHO, etc., etc. Yeah. So that they represent their voice. It's not always what we want that it's voted, but at least that is democracy. Yeah? Yeah. The numbers they play. But it's very important to, and also the civil society have to watch, to align their vote to satisfaction or not, to write about it, to talk about it, but no other voice, guys, because it's government to government. So, but there is way to express what the civil society wants if something is wrong.
So over to you.
Okay, it's me?
Yes.
No, okay. Hello, thank you for all your comments. And so I'm Jing from Taipei Medical University, Taiwan. So I would like to have 2 questions and for Professor Tan and also for Global Fund. So I would like to ask Professor Tan, that's really interesting that China focuses quite a lot in funding the health system strengthening. So it's the horizontal approach of the funding. That's really fun. That's really interesting and really important. So I would like to ask about the rationale of this kind of funding approach, and also what's the real content of this investment. For example, human resources, the capacity building. What's that capacity building for? And what's the content, real content in that, in the terms of health system strengthening? And also, I would like to ask about the comments from the Global Fund. So all the academic reports shows that it's the best to combine a vertical and horizontal approach altogether. Is there any possibility or discussions regarding how to do in that directions in the future funding approaches, rather than currently still we see that the go different ways still? Thank you.
Thank you very much, Jean. So one question to Kun, which is really China's focus on health system strengthening. What's the content? And maybe I could even be cheeky and add on to that. How does this health system strengthening even take place in the first place? Because you mentioned it's a cooperation plan that China has with its recipient country. How does it set its priorities on what to strengthen? Is it set by China, or is it set, again, what we've been discussing, locally by the recipient country? So that's a question for Kun. And then for Calypso, the question on vertical and horizontal. And I'm not sure whether I couldn't write fast enough. What was the specific? But Calypso, do you get the question? You got the question, great. Okay, so maybe we will take your question, Kara, and then Feng. And then, okay, we have 5. All right, so to you first.
Great, thank you for the great presentation. So I'm Shinhye, working with MSF, also known as Doctors Without Borders. So funds, fundamentally, funds come from member states, from the states, be it bilaterally or multilaterally. And given the current economic situation, where most countries would probably be limited to increase further funding to support other countries or multilateral initiatives. Also, amidst all this, the new pandemic fund has been created, primarily led by the G7 and then subsequently by the G20. And we know that the funds are more politically driven than needs-driven, when the funds from the states are more politically driven. So amidst more competition for the limited amount of funds, how can the recipients of the funds, be it a country or be it a multilateral organization or be it even the bank, how can you actually be able to pursue your needs over the funder's political interest when there's so much competition for the limited funds that with more, and even with additional entities and more requests for health funding, amidst all this, how can you ensure that you have your needs there and not be swayed by the political interest of the donors?
Thank you very much for your question. Could I direct to Ines? Because I think you will have the perfect answer for this. Around how can recipient country be able to pursue your own needs, given that there is this global competition for funding? Okay, Kara, please, over to you.
Since Calypso name-checked me, I thought I would just say something briefly about this process of graduating from aid. And there's 2 elements to it. One, what does enable countries to spend more on health? It is either a period of prolonged economic growth, and there are many countries in this region that have done an incredibly great job of having their economies grow. The second is, what is the size of the public sector budget within that, which is also about tax efficiency, right? It's about collecting the right taxes that are broad-based and equitably managed. And the third is about what happens to health, is how much health is prioritized within the government budget. And that, again, is also, to an extent, it's a political choice. It's not a technical one. But I think that also then speaks rather nicely to this issue of transition. So how do you get to the point of shifting from being an aid recipient to perhaps not as successfully as China as being an aid donor, but at least out of that aid dependency? And I'd just like to draw the audience's attention to a group of papers that we launched on Tuesday in a special issue of Health Policy and Planning that we have two, Professor Tang was an author of one of the papers, and two of the panel members were on our panel on Tuesday. And I think those papers also have a lot of lessons in them about the process of designing and executing donor assistance that can better enable a successful transition. And by a successful transition, I think what we really mean is the ability to sustain the coverage of the programs that previously received donor assistance. So I think this, the papers are all open access, they're all available on the Health Policy and Planning website, and there's a very rich evidence set there about how programs can be designed to better enable successful transition and better enable sustainability.
Thank you, Kara. Thanks for your intervention. And I think that's also a very timely reminder that it's not just the aid that's coming in, but it's also around how countries prioritize the spending of the aid funding, the efficiency of the taxes that they collect. And I would like to draw in this point with what Ines kept highlighting, the bit about corruption as well, that whether corruption messes up the picture. So very important intervention. Feng, followed by Amy, and then Hong.
Thank you, YY. I'm Dr. Feng Zhao from the World Bank. Let me first congratulate YY for putting together such a wonderful panel, such a balanced panel. I have learned a lot. YY and I are both fellow PMC, PMAC, international organizing committee members. I really appreciate all the deep conversations here. Now, I want to make a comment. You know, I see the development work the best when you have several elements on the ground. First is ownership. You know, we hear clearly from Agnes, from Professor Tang, ownership, strong ownership in both countries. Second is strong governance, right? So that's a must. And the transparency, accountability mechanism is also there. So when you have those elements, everything will magically come together. So we have two excellent examples, which, you know, in our World Bank system, this is two countries we love to work with. Things will happen quite easily in the sense, and we can get the results. We're also learning from while we work together. We're learning a lot from this. You know, in Rwanda, Agnes, when you were there, you remember the result-based financing, which Rwanda played a key role, and eventually World Bank, you know, developed a new instrument instead of focus on all the nitty-gritty input-based financing procurement. And we call it Program for Result, P4R instrument, which we don't care about procurement. We just say, you know, whether you achieve the result indicator and the financing will come. That's originated.
Because, like
right.
I say, if you give me $10 million and I commit that I will put this amount of people on treatment for the malady X.
Exactly, yeah.
And I can do a road to a hospital and buy the medicine.
Exactly.
So that means with this approach, I can really do what my country needs.
Yeah. Rwanda was a champion of that, and then you can see it's also influenced development aid. And China, the same thing. I really love the quote Professor Tang you put at the end. In China, we learn from each other. You know, I think China maximized development financing. The financing is a part, but China always strategically use World Bank and other institutions for their pilots, for their strategy, for assessment. You know, I can give you an example. The procurement law of China is largely based on the World Bank procurement framework. That it was one thing, it's not money, but it has profound impact. We also learned a lot from the reforms on the ground. My point is, I really appreciate these two examples, and Kaliso also touched on that, Jeka colleague also touched on that. So when you have those ingredients, you know, we can easily, working together, we can learn from each other. So you got the gates behind me, I better shut up. So.
Thank you very much, Feng, from World Bank. Hong, maybe we let Amy from Global Fund. Amy, over to you.
Hi. Thank you, YY. This is Amy Naoka from the Global Fund. I know I would be very brief, and actually my question is quite similar to Kara's. successful transition. And I particularly would like to hear the view from Kun and also Agnes from the perspective, because the China has supported health systems like more than 90%, which is sometimes it's very hard to put it hand over to the country, because this year PMAC is talking about decolonization, which is ownership and also independence. So I would like to hear what is your approaches for this transition and financial sustainability. And I also would like to hear from Agnes, what is your approach when you working with donors? And also recently more and more donors try to pay attention to financial sustainability or domestic resource mobilization. And I would like to hear your view, how you have been seeing those current development, and what is your approach to work with them?
Thank you very much, Amy. So another question to you, Agnes, but I've noted them, so I'll remind you about that. Just maybe we can let Hong have one comment and intervention before we answer, and then if we have time, we'll take one more. All right, thank you very much. Apologies for that. Hong, over to you from Gates Foundation.
Okay, my name is Hong from Gates Foundation. Again, congratulations to the panel. I have a few questions. The first one is probably you already observed both EU and United States already made a strategy for the global health products development at the local level, right? So that's one of the kind of a strategy for decolonization, I would say. Recently, actually, I investigated those issues a little bit. One of the country actually built a global public goods factory in Uganda, but they never got order because their cost of produce that good are higher than China and then India, which is the largest the producers. So do our donors or the funding agency accept that there's a higher cost but really strengthen the capacity for local to produce these products? Are we ready to do that? Right, that's a question, because I've seen that even we build the strength and the capacity at the local level, the government of that country may not able to purchase. It's a global public goods, but do Gavi or Global Fund ready to purchase them at a higher price? That's the first question. The second question is goes to Professor Tang. We knew, I just saw your graph, most of China's investment is bilateral, right? So, but there's a huge push from a global community say, why not China join the multilateral mechanism, such global fund, such Gavi, to contribute that as a donor? I knew China refused to tell themselves as a donor. They always use development partner rather than donor, right? But there's a huge demand for that. In your view, do you think China could become a multilateral donors, contribute a multilateral fund, such global fund, Gavi? So the third one is about the concept of decolonization. When we talk about the decolonization, well, the opposite word is independent, right? So the independent is not just mean the decision. The independent of a decision is independent of resources as well, right? Last couple of years, I work on the poverty alleviation issues. And all those regions at the poverty level refuse graduate, because once they graduate, they lose the support, right? So the question is, do the donor agents has the plan for exit, the exit strategy? Do the receiving country has the plan to graduate, to become a independent, and eventually decolonized. Thank you.
Thank you very much, Hong. So, great audience. So we have questions from Gates Foundation, we have inputs from the Global Fund, we have World Bank. Right, I have many funding agencies here, so lots of touch points later on after this session ends. But let's come back to the question by Jean. And I'll remind the audience and the panel what were the questions. So Jean, you have a question for Kun. China health system strengthening, what's the content? And also, I expanded on that. How do you even decide and work with the local government on what is the nature of the cooperation that is necessary at the local level? How does China achieve that?
Okay, well, let me try to answer one by one. The rationale behind China's infrastructure approach, right? I guess that have to do with China being a newcomer for development aid for health. I mean, if you look at the aid behavior of all these different agencies, even the World Bank, before 1970s, their key focus was on infrastructure. So this is what they're good at. And infrastructure building is, by the way, what we are good at. So that, I think, the same with JICA. If you look at Japan, you know, before it was still focusing on infrastructure. I mean, that's the easiest approach, I guess. But gradually, when the donor become mature, and it will gradually march into the arena of health, human resource development, for example, or the capacity building or other health interventions in the communities. So I think China is still at the very beginning as a donor, development partner, by the way. So I think we still are exploring different ways, but the infrastructure is what we can do at the moment. And in terms of what the contents are for capacity building, let me give you an example because I work on maternal and child health. If you plot the GDP per capita versus China's maternal mortality, you will find that at any given level of GDP per capita, China has always have a lower maternal mortality or infant mortality if you compare with other countries. So that is to say, it's not just economic development that helps to push forward the maternal health. It was really something that China have in our system, in our experience that we can share with the world. So that is what we are trying to build the capacity in other countries. So it's summarizing what China have been doing in the past, how we achieved to this stage of maternal health, and we want to translate or transfer those knowledge to other developing countries. So that is the capacity building contents that you are asking. And about the need, whether the need are from the recipient countries or from China, so I can only give you this example that no project can be approved if it's not from the recipient countries. That is to say, all the proposals sending to the China Aid Agency will have to come from the local government of the developing countries. So for us, you know, sitting in Beijing, I mean, they won't listen to us. So that is to say, all the needs, we really want to do our most to make sure that it's from the ground, from the grassroots, rather than someone from like the high up. Let me pause here. I think there are also other questions I can answer later on. Thank you.
Thanks very much, Kun. I hope that answers Jean's particular point on China. And then Calypso, Jean also had a question for you, which is around this notion of combining vertical and horizontal strengthening.
Yeah, I think it's a good point. But I think the global funds come a long way. There's a lot of health systems elements, grant making, and a lot of separate component even on health system strengthening. But I think there's certain functions that I think the global fund can support, like for instance, things like supply chain procurement, when countries, get able to quantify demand, to bring the products in, negotiate, purchase, get the products where they have to be. And these are core building blocks of a health system, and that's the sort of thing that the global fund can help with, or lab systems, surveillance. And it showed during COVID that a lot of the investments that had been made with global fund support helped with responding to COVID. So the gene expert tests, for instance, which could be repurposed to be used for sequencing of the virus, were used that way. Or indeed, even getting the vaccine. Our Gavi colleagues used a lot of the infrastructure for malaria for net delivery, because this was not an immunization campaign targeting children, it was one targeting adults. And so those supply chains and mechanisms for getting the nets out to people remotely were used to get the vaccines out. So there are these elements, but we're a lot more intentional now working with our partners in countries to target intervention, well, money towards interventions that strengthen health systems. And I don't think it's an either or necessarily. And in certain countries, still, diseases such as malaria are as crippling as COVID was or was feared to be in the global north. And we've shut down our healthcare systems and our economies at great cost to the world because of COVID. And many places in Western Central Africa, malaria is that. And every day in primary healthcare centers, they have to deal with malaria. And unless it's addressed, there's no capacity at the primary healthcare level for the system to deal with anything else. So I think you're absolutely right, and there's a shift, but I think it's also this division between vertical and horizontal is a little bit at times problematic. And the answer our colleague gave on what is actually health system strengthening shows that, because it's not clear what it is. I totally take your point on maternal mortality, and I was wrong to say it was just about economic growth. In fact, as China was growing in the late 80s, early 90s, the health indicators became worse because you endorsed more sort of market approach, and the models of maternal and child health that the previous regime had built, the sort of crippled a bit, were abandoned, and then built again with a new commitment of the government towards UHC, and you saw the indicators improve. But what is it that you actually do in sharing? Do you tell them a story that how you did what? And I'm not saying this, I'm not being facetious, but that's why verticals have thrived, because they show specific results that donors can measure.
They have tried for you, not for us. No. A vertical program is the killing, because if she develops something very good vertically, when she's going, I remain with nothing. So, no sustainability with verticality.
Yeah, I didn't mean that to say that it's wonderful, but I'm saying that donors like results, right?
Horrible.
But donors like results, and that's why it's attracted.
We don't care about donors what they like. We want to save our people.
Okay. Yeah. Well, stop taking the money then.
No, I take the money. I don't like you. I take your money.
Actually, this ties in with one of the questions that our colleagues from MSF have asked,
yeah,
which is exactly on this particular point. And our colleague from MSF reminded us that increasingly aid funding around the world looks finite. And there was this example that she raised around the pandemic fund. But at the same time, how can recipient country really have that luxury to choose? Because there's this possibility that global funders would actually say that if you don't want these funds, there will be other takers. So you're on your own,
yes,
but the other takers will want
to take. We have to tell them that it's not their money. They are just workers to manage that money that is for us. So it's like my banker. He doesn't have to dictate me if I'm going to buy a blue dress or a red dress. I buy the dress I want. And this is the something very vicious in very good donors. They believe they know better what is good for you. And they forgot that they are not the owner of this money. It's money collected by their people for them to manage, for us to develop.
And actually, since we have you, Ines, I want to push you a little bit more on the point that Amy and actually Hong both mentioned, Amy from Global Fund and Hong from Gates Foundation. Because Hong's third question aligned with what Amy was asking. What is that recipe for successful transition towards financial independence?
Economic growth. And for economic growth, we have to go to the big picture now. Could the Western world stop to steal goods in Africa? We don't need any money from the Western world if we can manage our natural resources ourselves. There is $700 million a year we are stealing from Africa every year. With this, we can support health sector in Europe and build our own. So everything is linked, not related necessarily to the health sector. When you come in a country and you allow people to steal diamonds at very low cost and go and buy and sell it at very high cost, and after that take a portion of this money to help you to remain alive so they can continue to steal, this is hypocrisy.
So I want to throw a spanner to this logic. And then I'm very happy to be criticized, because this is exactly what Hong asked in his very first question. He asked about this local production pipeline for pharmaceuticals and vaccines. And I think because of the COVID pandemic, countries are starting to say that we need to have our own local production. We need to be self-reliant. Waiting for a global aid that probably would never come in time is dangerous. So for many responsible government policymakers, they think now that if I'm responsible and I'm a policymaker, I should actually develop my local capacity. But Hong raised this point. When you have your own local capacity, there's this issue of efficiency. Does it cost more? And I actually want to expand on that. It's not just a matter of cost. It is also a matter of quality. It is also a matter of regulation. There will be complexity in that. And clearly we wouldn't want 193 boats to be manufacturing, cabins. 193 cabins to be producing their own vaccines or their own pharmaceuticals. But what is that solution in terms of wanting to reach that compromise between allowing national resilience against outbreaks, against national needs, versus this issue of efficiency, pricing, quality, regulatory oversight? Saida, may I perhaps ask you, what do you see this issue from a JICA's perspective? Because I think JICA has been helping countries very much to develop a country from a national perspective, not just always from a health perspective.
Yeah, it depends on the population size or geographical situation and so on. For example, a Pacific Island country has a very small number, and the transportation costs a lot. So they, from before, they purchase the drugs and the medical equipment as bulk, and they can negotiate the price. And in Africa, they have a willingness to develop a regional network to procure medical equipment and the regional setup of vaccine production. But I think it depends on the road construction, road network, or air flight availability, or something like that. So I don't have one single answer. It depends on the situation in the region and the willingness of the region and each country. Yeah.
There's some fact. If you look, for example, Rwanda, below Burundi, and East Congo. East Congo is near from the oceans near Kenya, then to the other oceans near the capital city. So that means if we want to do pool procurement, and Global Fund agree on that and others agree on that, they should procure with a totally other political entity, which is East Africa. And this is legally problematic, because to procure together, countries in East Africa has enacted East African laws on procurement. But we cannot include Congo because it's another regional political entity. So the only solution will be to go to African Union and have a regional entity. So we need another approach, really. But this is the solution, because like my country is a little country, the country below Burundi is a little country, we have big country near us, Uganda, Tanzania, Kenya, and Congo. if we cannot procure the two of us together, it's a lose of synergy. We should really go with other countries and align the laws to that. And that's not always easy. Not always easy because of tension, because of unrest between countries and lack of trust, etc.
Thank you very much. And Kun, last question to you. And it's a combination of a few questions, which is, one, it's China's movement right now is mostly bilateral. And why hasn't China signed on to a multilateral partnership? So that's the first part. And then secondly, I think there is that question also from Amy that was for China. China, in a way, has transited very successfully. How has China done that, and what are some of the secret ingredients for that?
Okay, I'd like to answer the second question first, because I don't quite agree with Anis with regard to the fundamental reason to drive successful transition. Talking from China's experience, as I said earlier, before we get rich, we already see improvement in our indicators in public health. So I do agree how economic development is something very important, but it's not the only reason for healthful improvement in public health. So it all depends on your national prioritization of health, your political commitment, your allocation of resources, a whole lot of things. So economic development is not the only reason for that. So I'm glad that Professor Hansen has brought up this special issue that we just published. So there are several experiences that we can learn from, at least from the China's experience. For example, you have a transition plan right at the very beginning of the aid project. For example, you share the infrastructure of the governance of project with the government. So basically, that is to say, the one who implement foreign aid project are the same people who work in the ministry. So when the aid projects withdrawn, then you still have the human resources in the ministry who can continue on, and they advocate for allocation of resource for the aid transition after the funding is gone. And also, we found another very important aspect is to build local capacity, where if you look at the aid programs to China, they have built the capacity for example, health planning at the county level. They have paired up the Chinese experts with international experts, so they make like a mentorship sort of thing, so that makes sure the continued technical support lasts even after the project ends. And you have this continued advocacy for this project at the very beginning of the project. So those are some examples of how we successfully transited our aid programs. And by all means, this is not an exhaustive list, and I invite you to refer to our special issue to look at the details. And the last question is about why China do not embrace the multilateralism. In fact, we do, actually. So if you look at the Global Fund and Gavi, China actually have a share of contribution to those organizations. It's just we are not the major donors to those organizations. I mean, I guess there are several reasons that China is a bit hesitating to join the global community or the multilateralism. I think for number one, if you remember the 5 principles we were talking about, one of them being independence. So we don't want to be dragged into some agenda of someone else. So we do want to have our own independent agenda in terms of development. And I think this is similar to a lot of other donor countries, that there is a fear that if we merge our funding into this multilateral pool, then we'll probably lose visibility. And if you look at other development agencies, they all like compete for visibility in countries. So I think that is a frank reason, but is a reason with a lot of donors as well. And I think one of the fundamental reasons is the system incompatibility. As I said earlier, China is a newcomer to the development aid for health. There are a lot of rules, regulations, systems, procedures that China is not familiar with. I can give you an example that China is running a joint collaboration with several African countries and UNICEF. And it was 5 years before China finally made a deal with UNICEF, for the reason that the UNICEF have their integrated reporting system, so they don't need donors to report separately, but China insisted that we need them to report to us quarterly. So you see, those are like misunderstanding or even lack of experience working with those international organizations. So we don't know the rules that have already been set up there. So there are a lot of negotiation. China really need a lot of learning to be able to work with the multilateral agencies. So that's my question. Thank you.
Thank you very much, Kun. So I think today we have started with the topic of really looking at how decolonization is really is impacting the way that economics. Sorry.
We're saying 2 hours. We said how we're going to get through it, and look,
it's too short.
We want to talk more.
Oh right. See, we could go on, but
it's only 1 hour.
So my panel is now blaming me that we didn't factor for 3 hours, because clearly I think there's a lot more input and discussions that we could have. But I think we started talking about how there has been an evolution on the way that economic distribution has happened in the world. And our panelists, comprising 8 agencies, donors, as well as 2 country representatives, have actually reminded us on a few important lessons, particularly that it is never just the local priority setting agenda, but are countries themselves ready to discuss this with the funding agencies, with the development partners? Do they know their priorities? And at this point, this is where Ines reminded us that the health sector development plan must always align with what the country is planning to do, and to negotiate as one, that with development partners, how does the health plans fit in with the overall plan? And I think, Kara, you also reminded us that it is never just about external funding aid, but also how is internal funding even mobilized, and whether there is the tax efficiency that you talk about, whether there's the corruption that was highlighted, and whether there is a design, an explicit design to transit out of aid reliance. And I think Feng highlighted the bit, I made a note, he highlighted 4 points: ownership, governance, transparency, and accountability. Ines added 2 more points: coordination and cooperation. I think those are some of the very important points. We have also heard Kunt speak about what China, the evolution as a fund recipient to now a funding agency and a funding country. And clearly, I suspect there will be many more developments that will come, but it has been a great discussion, and I do thank all of you for spending 2 hours, especially as a very active and engaged audience. But if I could ask all of you to please show a round of appreciation for our panelists. Professor Calypso, Her Excellency Ines, Dr. Saida, and Professor Kun. Thank you very much for spending time with us.